All right. I hope everybody had a great lunch. Got some sunshine. We're going to be starting the afternoon session right now. It's my pleasure to welcome Dr. Seth Smith. Seth is a professor of radiology at Vanderbilt University, where he's the director of the Center for Human Imaging at Vanderbilt's Institute of Imaging Science. Dr. Smith's research focuses on the translation of advanced MRI methods to human diseases such as multiple sclerosis and optic neuropathies, which includes the quantitative assessment of spinal cord and optic nerves at both high and low field strengths. This afternoon, Dr. Smith will be highlighting his exciting work applying structural and functional spinal cord MRI techniques to better understand the mechanisms and clinical trajectory of multiple sclerosis. Thanks for being here, Seth.
Hey, I really appreciate the opportunity, and I apologize for not being there in person, but this is really great. So thanks for organizing and for the kind introduction. So let me try to share screens here. Okay. Can everyone see that?
Yes.
Maybe thumbs up? All right, I see thumbs up. Right on. Okay, so I was given the topic of covering a little bit about MS and spinal cord imaging and MS, and of course, that's really quite a broad topic. And what I hope to do over the little bit here is just give a smattering of different types of methods, things to think about, things that maybe are relevant or potentially even stimulate discussion about new opportunities and new directions throughout our exploration of MS. So I always like to start most of these types of talks with a little bit of history. And I've been studying this book by Carswell, and this was some of the first drawings of disease in the human body. And I found this really fascinating when I actually started reading the text. We've always seen the pictures. I'll show some pictures in a minute, but we started reading the text.
Recording in progress.
And the text here, I've got a couple of things here to look at. So it says, you received my first attempts to represent by colored delineations the healthy and diseased appearance of the human body. And this was during some lectures that he was receiving. And the statement at the very end said, I devoted a lot of time to drawing these things. And, this is the means of extending our knowledge of diseases, because that's really what we want to do. And if you flip to the next page, there was a comment that was made that really struck out to me, and it sort of is the basis for a lot of what we're going to talk about today. And what Carswell said was the great difficulty and frequently the impossibility of comprehending even the best descriptions of the physical or anatomical characters of disease without the aid of colored delineations induced me to undertake the publication of the present work. So basically what he's saying here is, if we can't see it, it's really hard to understand it, even partially. So this is sort of the motivation for talking about spinal cord imaging and MS and some of the advanced technologies that we're talking about, not necessarily the end all and be all of the methods that we have, but if we can't see it, it's really hard to understand it. So clearly there's a need for improved spinal cord imaging. We can go around to different hospitals and research centers, and we can see good images, we can see bad images. We can see consistently good images, consistently bad images. We can see images that highlight pathology. We can see images that maybe don't highlight the pathology the way that we want. So clearly there's a need for improved spinal cord imaging. Ultimately, that's why we're all here, is to talk about spinal cord imaging. And what we're going to talk about is we're going to talk briefly about MS. And I want to really bring up 5 different areas that we're going to look at. We're going to look at the macroscopic. So this is morphology and structure. So the mesoscopic, the intermediate here. So we're going to be looking at macromolecular features. And then we're going to extend this to microscopic, looking at axons and, sort of we understand that's going to be diffusion. Look a little bit metabolic. And then I couldn't really think of another word for vascular, so we call it vascular. And what we will do is we'll kind of interleave 3T and 7T, and again, just a little bit like a smattering here. So we know about MS. We've talked about MS. We've learned about MS. We're learning more about MS even as we go through our work. We know it's an inflammatory disease. There's demyelination, there's axonal damage and loss. Clinically, the diagnostic picture is that there needs to be lesions that are disseminated in time and space. The addition of CVS and PRLs and things of that nature into the new diagnostic criteria is really exciting. But we understand that there's a complex symptomology, a complex presentation, and a complex progression of many MS patients. We know it affects the brain and the spinal cord in various ways. But if we go back to this same Carswell illustration again, 1838, so 187 years ago, this was commented on in this particular drawing. It says it represents the transverse section, so A and B over here on the left, the transverse section of the cord spelled with an H, we don't do that much anymore, to show that the discoloration commences on the surface of the white and extends inward into the gray substance. And this was one of the first discussions of how the spinal cord is damaged in diseases like multiple sclerosis. But this is also one of the first mentions of lesions that don't necessarily spare the gray-white boundary. A lot of the pathological features we see in MS currently was sort of brought up about 187 years ago. And we see this in clinical imaging. We see this in research imaging. We can start to describe and delineate lesions. And so that brings us to our first topic, looking at the microscopic, the structure, the morphology of the cord in MS. And we said earlier that there's definitely a need for improved imaging. When we start looking at our clinical images, a lot of times we see lesions here shown on the T2 here, left dorsal column lesion, difficult to see on the T1s. And maybe we see something here in the left lateral for the T2s. But with improved imaging, with different types of imaging, different sources of contrast, things like the multi-echo gradient echo sequence where you merge echoes together, and this would be equivalent to the merge sequence or the MEDIC sequence on different vendors. Those lesions really start to stand out quite a bit more than they do even on clinical imaging sequences. But in order to make that jump into the clinic, there has to be a lot of testing and evaluation, and that's some of the first things that need to be evaluated. And, there's been a lot of work quantifying the gray matter using the phase inversion recovery, a lot of work that has shown that we can segment gray matter, look at gray matter atrophy, and it turns out gray matter atrophy in the spinal cord is super important because it ultimately drives a lot of the disability that we see. If we flash back to one of the representations of Atlas in 1996, so this was Atlas's book on what we expect to see in image quality. 1996, it's not too long ago. Some of us remember, like myself, remember 1996. Some of you may not. We've certainly come a long way. And certainly some work here at Highfield, Virgine's group, and Adrian Dula, we can really start to describe and see. We think back about the Carswell illustration, that if we can't really see it, we can't really talk about it. But we're now really starting to be able to see the morphology of the tissue within the spinal cord. We start to understand what lesions look like, where they appear, how they involve different parts of the spinal cord, what the prevalence are. We've seen some excellent publications over the past several years talking about the prevalence of lesions in certain locations in the cord. And that has been driven by our ability to image better in those areas. And certainly in order to standardize these protocols, in order to be able to offer something to the clinic, there needs to be some attempt at standardizing the methods, being able to analyze this. And this is the work from Julian's group and a lot of sites together, put together data to understand really what does the spinal cord look like. And, when we think about the spinal cord, we have to also understand that it's a long linear organ, not just a short segmental organ. And when we look in the literature, we see a lot of literature that points to the cervical segment or looking at cervical spinal cord involvement. But remember that there's a lot of the functions of the human being that are driven also by the thoracolumbar spinal cord, and we know that there are lesions there. So starting to look at that area, this publication from 2022 talks about the optimized multi-echo gradient echo sequence, excellent delineation of white matter and gray matter, and understanding that the white matter and gray matter looked very different down in the southern part of the cord. and moving to applying other mechanisms to create contrast and magnetization transfer, for example, which we'll talk about in a minute. So some of the work from Kristen O'Grady in her lab, looking at the ability to describe lesions in the thoracolumbar cord and start to see that there are fairly large lesions that involve that part of the cord that may be detrimental to the patient's well-being. So now we want to move to the mesoscopic. So now we're talking about myelin sensitive. We're talking about macromolecular involvement or macromolecular content. So we typically think about that in the central nervous system as being largely driven by myelin. I won't belabor why we think it's mostly myelin, but a lot of the exchange phenomenon that goes on, the relaxation phenomenons that go on, driven largely by myelin in the central nervous system. So one way to sort of probe that, we know that myelin loss and myelin damage and potentially even myelin repair and remyelination are hallmarks of MS in the cord, and being able to quantify the myelin water fraction, how much myelin is there, is really important. And we've seen the evolution of myelin water imaging and myelin water fraction over the years, moving from a very long scan to a much more rapid scan to be able to characterize what is the myelin content. And it's been validated histologically with postmortem samples and shown that this actually is a strong measure that is reflective of myelin content. And moving from 24 minutes to something that's very rapid, very accessible, has been one of the hallmarks of the group. Here, just an article from Adam and Shannon Colan's group at UBC, where they're able to make myelin water imaging something that's very approachable and rapid to start to assess the health of the spinal cord. Magnetization transfer has always been our old standby to look at myelin imaging. And myelin and magnetization transfer typically is thought about as two different pools. There's a macromolecular pool and there's a not macromolecular pool, or one way to think about it is a water pool and a not water pool. And the water that we typically image in conventional MRI is going to give us information about inflammation or water content change. We're going to look at relaxation times, T1 and T2 spin density. But there's also another set of protons that can provide information, but they're typically silent to MRI because their relaxation time is so short that we can't capture that directly. We tend to think about those as protons that are intimately associated with large, sticky, slow-moving macromolecules, which in the central nervous system is largely thought about as myelin. And the pathology we could be sensitive to there would be demyelination, potentially remyelination. And the way this is done, typically a magnetization transfer experiment is done where we saturate at an off-resonance frequency, and then we don't saturate, and then we compare those two, and we create what's called the magnetization transfer ratio. And the magnetization transfer ratio is semi-quantitative, but it's very rapid, and that has some benefits there. Quantitative magnetization transfer, a lot of times has been thought about as it's too long, it's too complicated, it's difficult to do, it's difficult to do in the spinal cord. While all of those are true, there have certainly been quite a bit of advancements over the past 20 or 30 years that allow this to be more feasible or more approachable in the spinal cord. And what quantitative magnetization transfer does is, rather than just saturating and not saturating, the idea is to take a bunch of images where we saturate at different frequencies, apply the model, fit to the model, and then try to back out things like the pool size ratio, which is a reflection of the macromolecular content of the tissue. And we've seen work that was done by Adam Smith years ago, where we look at the pool size ratio here, and you can see gray matter is lower than white matter in red. And in MS, where there's a dorsal column lesion, we see that the quantitative magnetization transfer pool size ratio is much lower than the surrounding white matter. So this is sort of expected. If there is loss of myelin, then we expect the magnetization transfer phenomenon to change. But again, considering that spinal cord is a long linear organ, there are other areas that would be interesting to look at. And some of the work that's being done by Gabby Dunay in Kristen's lab is to look at the quantitative magnetization transfer of the thoracolumbar cord, because there's a lot of myelination phenomenon that's happening down there, demyelination is happening there as well that deserves to be looked at because of its implication in walking, in bowel and bladder dysfunction, and neurological function loss from the lower segment of the cord. Now we want to transition again to look at the microscopic. So what about axons? We know that axons are damaged in MS. They're sometimes lost, and we want to be able to be sensitive to that. So diffusion is one of the ways that we can start to look at the subvoxel information that is contained in the tissue. And we typically think about diffusion of water in restricted environments where the diffusion is going to move either along or across the axons. And then we can calculate sort of our standard axial diffusivity, radial diffusivity, mean diffusivity, and fractional anisotropy for those tissues. And we say, well, if there's going to be tissue loss or axonal loss, then there's going to be changes to some of those diffusion parameters. And this has been work that has been pioneered years and years ago, starting back potentially even before this. These are the ones that I sort of started reading when I started in the field in 1998 and even beyond, where we can indeed get information from the spinal cord using diffusion. And we've been able to move that needle quite a bit further now, where due to the benefit of the spinal cord toolbox, which is quite possibly one of the most awesome tools that have been brought to the spinal cord community, it allows us to start looking at diffusion phenomena in the white matter, in the gray matter, in the different funiculi, in the different levels, and to be able to register all of that together and look at lesions and how does that change. So a lot of the analysis methods that have been developed over the years are coming to really power our ability to study diffusion in the spinal cord. So diffusion tensor imaging is sort of our basics. So we have single shell, we can acquire multiple directions and be able to look at white matter, gray matter lesions, and using tractography to be able to start to look at the columns of the spinal cord that are involved in MS and how much are the columns involved in MS. So you can see here for the right dorsal column that was segmented out, we can see that there is this pink area showing that there's involvement throughout that particular dorsal tract, and next to it, a patient that has another tract that's significantly more involved with lesions. And we can start to characterize that rather than saying, okay, well, what's the region of interest of the cord? Can we look at the lateral columns? Can we look even within the columns and start to ask questions about what columns are damaged and how much are they damaged? And in fact, what's interesting about this is that when you look at the whole cord, diffusion tensor imaging, here shown, we have our fractional anisotropy, AD, axial diffusivity, radial diffusivity, mean diffusivity. We find that the FA at different levels within the spinal cord are different between healthy controls and MS. It's not surprising. But what is surprising is that when we break this down and we go from the whole cord to looking at the white matter only, we find that pretty much the same thing abounds, which is not to be unexpected. And then when we move to gray matter only, we find that the gray matter plus the white matter don't tell us a ton more than just looking at the whole cord. So there's a lot of value in understanding that because it allows us a more rapid assessment of the diffusion phenomenon in the cord. Moving again south, work from Alicia Cronin in Kristen's lab to develop not necessarily the single shot. So again, we're not taking an imaging method that works up at the top and moving it down to the bottom. We're actually saying we have to tailor this for the anatomy of interest and doing a multi-shot sequence of multi-shot diffusion. So this is a image navigated or a 2D navigated multi-shot sequence. And what you can see is compared to the single shot where there's a significant amount of distortions, a lot of that is cleaned up in the multi-shot sequence. And this allows us to characterize the difference between white matter and gray matter, to generate contrast between white matter and gray matter in the FA here, and also some contrast here in the radial diffusivity between white matter and gray matter. So if we can do that, then we can start to ask the question about, well, what do lesions do? What do the MS chords look like in that lower segment as well? And the thing is, but wait, there's more. So years and years ago, when we first started doing this, when our community started doing a lot of diffusion of the cord, we were sort of limited in what we could do. Maybe it was scan time, maybe it was corrections, maybe it was analysis. But now we're at the stage, especially fed by a lot of the information that comes out of the brain, that there are many different ways to acquire and analyze and ask questions about diffusion of the spinal cord. And we can get all these different parameters, especially looking at free water models, spherical mean techniques, naughty models, standard models, all these different aspects of what we can acquire now. And this sort of originated with the earlier work that was multi-B imaging that was done by Jonathan Farrell and some of the early naughty work that was done out of Oxford. I'm sorry, UCL. I misspoke there. So multi-B value feeds this idea that we can start to propose more models and look at things like naughty, for example, in the spinal cord, where we show that compared to a healthy control, the orientation dispersion, for example, is different in patients, in MS patients compared to our healthy control. But wait, there's more. So when we look at all these models together, we start to ask the question about which one is best. How do we do it? Can we really do all this? And the reality is that we can acquire a lot of data really fast now. We've gotten a lot better at that. And we can apply corrections like denoising. We've got templates available to us in the spinal cord toolbox. We've got ways to analyze our data better than we have before. So it's not inconceivable to acquire a lot of data and be able to fit a lot of different models and get information out of the cord, especially in patient populations, and generate maps of various things: extra-axonal mean diffusivity, intra-axonal diffusivity, axonal volume fractions. We can do all sorts of things with that, and we can start to compare those with the brain and spinal cord and look and see what's different. So shown here on the upper left is from the free water model, looking at our different types of imaging outcomes we can get here: fractional anisotropy, AD, RD, MD, things like that, free water fraction. And when we look at this in the MS cord, you look at it and you say, well, I'm not really impressed that there's a major difference. And I agree with that. But we can look at a different model and look at different types of anisotropy that would come from different models, such like naughty and the standard model. And these are all reflective of different aspects of anisotropy. And when we look at this in MS, you look at these two cord maps, say here, and you say, well, Seth, I don't really see that much difference between the two. Totally agree. But what the question is what do I choose? What are the methods that I want to choose? What are the analysis routines I want to use to be able to ascertain information about the spinal cord in MS? And how does it relate to disease? And it depends on what you're looking for. My kids always get mad at me when I say it depends on what you're looking for, so I put a picture of them just to embarrass them. Fortunately, they're not here right now, but it really depends on what you're looking for. And when we look at the difference between healthy control white matter and normal appearing white matter, we do this in the brain and we do this in the spinal cord. And what we find is that things like the diffusivities that come from the different models, but there's sort of all measures of diffusivity, tell us a lot of difference between an MS lesion and MS normal appearing white matter. When we look at healthy control versus normal appearing white matter, we see different types of features here. So for example, it's the anisotropy in the cord that tells us some information that might be useful, as well as diffusivity. So again, I think it really depends on what you're looking for, where you're looking for it, and what type of effect you want to exploit so that you can use your imaging method to understand sort of the pathology there of interest. So we'll move on now to the metabolic. And we think sort of about two different types of metabolic imaging. One, spectroscopy. Can we get information about neuronal markers, NAA, choline, creatine, myoinositol, GABA, glutamate, those types of things. And the second one is that how does the spinal cord function? Is it damaged? And when it's damaged, how does it change in its function? So the first work from Anke Henning's group several years ago, looking at spectroscopy of the cord, a lot of challenges here. And one of the biggest challenges is that number one, we're looking at a small region of interest. Number two, the field inhomogeneity is kind of a pain. It is both a spatially varying as well as a temporally varying magnetic field change. It changes with breathing, respiration, and the bone disc interface. So a lot of challenges there, but some really interesting work early on about trying to do spectroscopy and understand sort of the metabolites of the cord there, and certainly more work to be done there, but it is quite a feasible opportunity. So I always, try to weave in history here and there. And one of the people that we've read over the years was Galen. Galen was the personal physician to Marcus Aurelius. He was a bit cocky, and he thought that he understood everything. He even wrote books about how he thought he understood disease. And we're talking about 1800, I guess 1800 years ago or so. And he wrote this, and he says they, and it's unclear who they is, but he tended to upset a lot of people when he gave his presentations or when he spoke on the Senate floor. He said they do not even know that there are specific roots of nerve which distribute to the skin of the upper limb, allowing for sensation, and other roots which form branches that move the muscles. So what he's describing there is the structural functional relationship between the cords and the nerves and how those ultimately translate into the function that we observe. And we'll talk about the fallen sophist here in a second. But he's making all these statements and he's saying, well, people don't understand this. I don't understand why people don't understand this. And the reality is that maybe he had some nugget of truth there, but Alexander of Aphrodisias said that Galen is stubborn with unmatched hard-headedness in debating and contradicting, and he is an asshead. So we sort of just take that with a little bit of grain of salt there. But Galen told a story, and it's unclear if the story was true or not. But what happened was there was a guy riding down the street on his horse. He fell off his horse and ended up hurting his spine. And when he did that, he lost sensation in his hands and feet. And what the doctors at the time were doing were they were putting potions on his hands and feet, trying to regenerate the feeling and the motion, the motor function of his hands and feet. And Galen came through and said, no, you don't understand. You don't really treat the hands and feet. You want to treat the injury site, which was the cord. And he evidently had a potion that he was able to rub on the back of this individual. And as the story goes, he got up and walked. So Galen at that point talked about the importance of the spinal cord's function to ultimately the function of the nervous system, the human body, and what we do. So he was sort of the first to report the variegated pattern of neurological impairment. So that brings us to our topic of conversation about fMRI and functional connectivity in the spinal cord. And certainly a lot of work has been done here by Patrick Stroman, Joe Kong, John Burks, and Rob Berry, looking at can we get functional information from the spinal cord. And the reality is that yes, we can. This is sort of the early work from Rob Berry. We call this sort of the 8-bit functional imaging, and then moving to 7T and better imaging methods and algorithms can start to look at better and better resolution. Ben Conrad showed that you can acquire this in patients with MS, look at functional connectivity, and a lot of data here not really showing a lot of detail, but he said that at the group level, there's a difference between the controls and the patients and the dorsal column connectivity. But what he said importantly was that the lesions affect that. And that shouldn't be surprising to any of us, but what he said was that when you're in a slice, you can have increased functional connectivity or even decreased functional connectivity, depending on where the lesion is, and if the lesion is in an ascending or descending track and how that feeds the gray matter. And especially when you look through slices, it becomes much more complicated. So the short of it is that while we can look at functional connectivity between horns, when there's a change in the tissue health, the white matter health, the gray matter health, lesions that don't spare the gray matter boundary, then what we find is that our functional connectivity between healthy controls and MS patients can go up, it can go down, and we're also fighting the question about noise and whether or not these are measures that are reliable. And I think we've established, and the community has established that these are reliable, but it's influenced heavily by the magnitude, the multitude of lesions that show up in the cord. And again, owing to having better templates and more robust imaging methods and analysis tools, we can start to look at both region of interest and seed-based, also ICA-based fMRI, go through a series of processing. I'm not going to belabor this, but we go through a series of processing steps to be able to get access to the functional connectivity within the spinal cord, looking at regions of interest, for example, whether or not this is ventral-ventral pairing or dorsal-dorsal pairing, ipsilateral or contralateral, and how those ultimately are different between patients and healthy controls. And certainly we see ventral-ventral connectivity being a bit stronger than the rest of them, but indeed there are some differences between the connectivity patterns, and there's a trend towards increased functional connectivity in relapsing remitting patients with MS with low EDSS, and I'll show you that in just one second. But importantly, when there's a change to the health of the tissue, Ben Conrad showed this with functional connectivity, Anna Combs showed this with diffusion. When there's alteration of the tissue, the white matter, then there's ultimately going to be alteration of the function. And again, this should come as no surprise, but it is something that is quantifiable. And here on the bottom showing that as FA gets worse, we actually see, this is in white matter, as FA gets worse, we actually see a slight increase in the dorsal column connectivity. So there's some sort of inverse relationship here, but it's much more complicated than that. And when you look at the relationship between functional impairment of the cord and neurological impairment of the person, there are some things that pop out. For example, there's some relationships with timed 25-foot walk, with timed up and go, so standing up out of your seat, walking, coming back, sitting down, and lesion burden. We would expect that. But there's a complex relationship with the EDSS measure, and we understand the benefits and the weaknesses of the EDSS measure, but there's a complicated relationship that shows a little bit about how connectivity may change downward, may change upward, and statistically there's trends on various ways that this changes. But when we start to look at ICA and look at the individual components of the spinal cord, we can start to identify the different areas of the gray matter and the components from the functional connectivity in such a way that we can look at the ventral, the middle leg between the ventral and the dorsal, both left and right, and also the central gray matter. And what's interesting is when we start to look at those features, we can identify and basically parcellate the gray matter within levels and between levels of the spinal cord. But what's interesting is that when you look at the comparison between healthy controls and these components, looking at the difference between the components in healthy controls and MS patients, in the MS patients who have barely detectable neurological symptoms, we find that there's an increased connectivity compared to healthy controls in various components. When that group now transitions, or when we look at a different group that has an EDSS of, for example, 1, we find that the majority of the connectivity patterns now are lower than healthy controls. So there's some sort of temporal change, or maybe some sort of change, maybe it's not temporal, but different levels of disease burden will generate different connectivity patterns relative to the healthy control. So the question you ask is, well, where are these differences? And this is maybe one way to look at it. So this is a C3, C4 comparison where we look at the interlevel, so the between level connectivity of healthy controls. And here when we go from EDSS of 0, where the solid lines tend to indicate that MS connectivity is greater than healthy controls. When we look at the connectivity for EDSS goes to 1, we see that there aren't any really that are higher than healthy controls now. They tend to be lower. And the same thing can happen when we look across different levels. Again, EDSS 0, EDSS 1, there's a change there. Also, some of the work that Anna Combs and Kristen's lab looking at functional connectivity of the spinal cord. Elizabeth Keeling's been showing, again, that we can identify different differences between the different networks in the thoracolumbar cord, just like we can in the cervical cord. And this opens up now the opportunity to start looking at the functional differences in the top part of the cord from the bottom part of the cord, develop similar connectivity matrices, and identify that indeed, again, we see some areas that appear to be less connected than healthy controls and some areas that appears to be more connected than healthy controls. So there's still yet a lot to analyze there and understand. So I'll close with the vascular here. And what I want to show very briefly is that with the adoption of the central vein sign in the brain as part of the diagnostic criteria for MS, it opens up the door for us to question how does this change in the cord? And just to remind you, the different vasculature, the vessels in the spinal cord, here the red being the arteries, blue being the veins. This is what we typically think when we look at Netter, but maybe it's a little bit more complicated than that. And indeed, the venous supply for the spinal cord is varied. It's different from person to person. But there's one thing that's a fact, is that when we looked across several MS patients, I think there were 24 MS patients at 7T, what we found was that there was a prevalence of an anterior spinal vein, much more so than a healthy control. And this was just an observation. And what this did is this prompted us to start looking at susceptibility imaging. So some of the earliest here in 2011, identifying some hemorrhage in the cord. And in 2022, Jensen Condering showed that there is potentially the presence of a central vein sign. And some of the results that we show here, I'm going to click through to one at the very end to identify that there are lesions that we can see in here, the left lateral column, that appears to have a very circular, so sort of the donut presentation of the central vein. And here in the right lateral column, we see a vein that goes through this way. And now what's interesting is that this is very different than the healthy control. And in fact, what we see is highlight this a little bit more, the central vein going through the lesion, here the central vein going across the lesion, but also the presence of paramagnetic rim lesions that we identify in the brain is marking a lot of maybe progression or smoldering inflammation. In the spinal cord, we're starting to see very similar features where perhaps these lesions have rims. There's a lot more to be done, a lot more to challenge this and ask questions about it. But I'll just skip here to the end. There was one additional finding that we found that appeared to be distinct in healthy controls versus MS, and that is the presence of this very dark rim around the spinal cord, which the radiologists feel was probably more diagnostic than any of the other central vein signs or paramagnetic rim lesions that we saw earlier. So where are we now? And we'll sort of land here. And a lot of words. I don't typically give a lot of words, but I think there's something important here that when we think about Galen, we talked a little bit about the history and the evolution of some of the imaging that we've done. The first thing that Galen wanted us to know is if you don't look, you're not going to find it. So there's motivation here for continued curiosity and poking holes in the prevailing methods in the spinal cord and to work hard to advance those and bring those further along. And then once you look, you may not find what you're looking for. So there's motivation there for improvements in scanner acquisitions, in analysis, in maybe even how we approach it and think about it. But the important thing here is that when you do find something, interrogate it, test it, evaluate it, and make sure that we don't make sweeping generalizations about, I see this, therefore it must be true across patients. And that was sort of brought to light with the fMRI, that we see that there's some functional connectivity, but it appears to change based on disability. And then at the end is we don't know the full story yet, but what we do know is that the spinal cord is important, it's involved, it's integral to our function. And frankly, it's really quite incredible in all that it does. It's incredible in our ability to image it. And sort of, until next time, we'll go ahead and close, just knowing that at the end of the day, the spinal cord is better than the brain. And there have been a ton of people involved. I can't list everybody here, or even the number of people that have been involved here, but I sort of want to highlight the people who either have been or currently are involved in our lab. Really grateful to them for all of their contributions. There's so many here to list, and they handle so much of the work that we've done in the lab. So I think with that, I will close and be happy to take any questions or open up a discussion. Thank you all for your time.
Thank you, Seth. That was An awesome talk. I really appreciate the historical perspective on things. I really like that being intertwined throughout. I'll start off with a question I have. When you've been able to identify the lesions within the cord, and now with the spatial normalization techniques, have you looked at just mapping where the lesions are across the cord? Do they show up randomly? Are they localized and aggregated across people when you look across? Kind of curious.
Yeah, I think there's been some work recently that highlights sort of the prevalence of lesions within levels. So, for example, do they appear more in the dorsal column or lateral column? Do they appear more in the ventral and dorsal? And a lot of the work that has come out of, I believe that was work coming out of Montreal that was able to show the prevalence in different columns. Now, the question you asked too, though, is what about through plane? Historically speaking, a lot of times we've thought about, well, there's the greatest prevalence of lesions in the cervical cord. And what's interesting about that is that in the early, I guess, 2000s, it was sort of thought that only about 50% of patients had lesions in their spinal cord. And there's reason to believe that because the imaging wasn't as great as it is, or even frankly as good as it is now. But also, not that many patients receive spinal cord MRIs when you're looking for diagnosis of MS. So that sort of goes to the first lesson a minute ago, is that if you don't look, you're not going to find. Once you do start to look, you do start to find. And what Kristen has shown, what other groups have shown as well, is that there are certainly lesions lower down. Pathology, histology has shown that as well. But it does appear to be person dependent. It appears to be severity dependent. But I would venture a guess that most patients have lesions throughout their cord.
And then, do you have any insight on what is being done imaging wise for these patients at Vanderbilt? And are they doing, full spinal cord imaging, any 3D imaging? Do you know?
Yeah, that's a great question. Clinically, it's sort of driven by the neurological impairment that's observed in the clinic, right? So if they feel like there's a lesion that's localized to C5, they're going to target that area. As far as total spine imaging in MS in the clinic using 3D type sequences, we don't see that too often. But certainly highlighting the work that Kristen and her lab has done at Vanderbilt to move some of the advanced imaging methods we have for the cervical cord to the upper and lower thoracic, which is a really tough area to image, but also the thoracolumbar, looking at the lumbosacral enlargement, and then moving further into the cauda equina or conus and cauda equina. So there is work being done to develop each of these imaging methods for different parts of the cord. But I do want to highlight that it's not as simple as assuming that this is a long linear organ where we can take something we've done up here and just slide it down the spinal cord and hope that it works. You have many different challenges at different levels. So there is almost a level dependent development that is being done to hopefully we look back on this in 20 years and say, oh, wow, look at this. We can cover the entire cord with all of these quantitative measures. But I'm not sure we're quite there yet.
Excellent. Thank you. Questions from the group?
Hi, Seth. It's Julien here. Thank you for your talk and for all the great work that your lab has been doing. I'd like to challenge you a little bit by like your first slide, where you are quoting someone saying that what's important in fact is to actually see the pathology. That's ultimately what makes us more confident for diagnosis. And then you went on with those fancy QMR techniques, QMT test, and then all those multiple diffusion models. And I guess my question for you, and I look back and I remember always that about this time where I was talking to Charles Gutman, who is a neurologist at the Brigham's 15 years ago, and I was watching more, some of his talks, and every time he was repeating that, all that matters, in fact, beyond those fancy QMRI techniques, is just simple, T2 star weighted or T2 weighted images where he just see the lesion and then looks at the lesion and he sees how it evolves. Now, as you pointed out, there's the central vein, which is central to the diagnosis also of MS, and that Atlee Witt nicely showed those that it's possible to see it in the spinal cord. But I would like to get your insights now that you've looked at multiple QMRI techniques. Do you feel that we should still spend time getting those complex multi-parameter fitting instead of just trying to get nice looking multi-echo GREs, for example?
So Julian, that's a phenomenal question, and I think in a lot of ways, it really is the central question that we all have to wrestle with. Is a really good imaging method that happens to be sensitive to the presence of lesions sufficient? And the other part of that is what is necessary for the patient to improve our understanding of the patient's disease, to improve our ability to characterize a patient who is recovering or a drug that's working. And you're really striking at the root of that question. And it's very hard to answer because I think, I have to give a disclaimer here too. I'm not a radiologist. I'm not a neurologist. I develop spinal cord imaging sequences for a living. I try to write grants on it and continue to get funded. So is that what we need to be doing? It's a great question. If I would just offer my kind of weak opinion on this, for diagnosis, to be able to say, to look at a cord and say, this is an MS cord, this is an ALS cord. I think our target does not need to be these fancy methods that start to get access to, or maybe model at least, the tissue changes that are underlying a lesion. What we've got to be able to do is we've got to be able to image fast and good and clearly to be able to identify what's a lesion, what's not a lesion. Does this look like MS? Does this look like a healthy control? And I think there our thrust is, can we make spinal cord imaging as accessible, as rapid, and as clear as a lot of our brain counterparts have shown? So many times we can look. We had this discussion with Kurt just the other day, and he said if I had to bet, then probably the best imaging that we could do is a flare, and it's a great point. Now, what I sort of like to think a little bit more about is that if we have biologicals, if we have things that we're giving patients to try to treat a disease or maybe protect against disease activity or follow improvements, a lot of times those improvements may not be as simple as, did my lesion shrink or get bigger? Did I have a new contrasting enhancing lesion compared to something else? And I think when you look at I'm sorry for going long here, but it's just such a tremendous question. I'd love to talk about this for hours. If you look across a lot of the clinical trials, a lot of times you get to the end of the trial and you say, well, we didn't have an imaging outcome that was as sensitive to the effect of the drug as maybe what we had hoped. And the question is it because we have an imaging outcome that maybe isn't sensitive to the biological aspect of what's changing with the treatment? I don't know the answer to that. But I do think there is a necessary activity to improve and to make the best clinically relevant images we can, but I wouldn't necessarily use that and say, let's not explore some of the advanced techniques. Sorry for the long answer, but that's a great question.
Thanks for a great talk. I'm not very familiar with MS and the spinal cord imaging side of it, so this might be a really basic question, but is there any literature that, like with some other neurological conditions, we can kind of, if we image before symptoms start, we can actually see the lesion before they become symptomatic. Is that, I think there's been some work done in the brain, but has there been any work done with that in the spinal cord? And do we have a clear understanding of like the structural changes that happen longitudinally with MS?
So to the second point, I think we do have fairly uh, a fairly good handle on the expected longitudinal changes that we might see in the cord and brain with time in MS. But to your point about imaging before symptoms become present, I think that is sort of something in the MS community that I know MS patients would really appreciate. I think that's something we just don't know because there's been evidence to suggest that by the time symptoms show up, even a first symptom of optic neuritis, for example, there's evidence that suggests that in at least 17%, this is what the optic nerve treatment trial said, in patients who present with optic nerve or optic neuritis, 17% of those already have brain lesions that look like they might be MS. And the definitive diagnosis of MS with an optic neuritis, if you have two lesions in the brain, for example, goes from 17% to like 57%. I may be misquoting those numbers exactly, but so the idea there is that it's very, very hard to get access to the genesis of MS with imaging. A lot of times we catch it later or a diagnosis is made. There's a hot cold sensitivity, maybe there's a weakness, maybe there's some cognitive fatigue or something. You go in and get checked out, and then you identify that this patient has MS. I think that we would all love to be able to have imaging markers that could predict MS or potentially could catch it in its earliest stages so that maybe drugs could be provided to minimize the damage. But I just don't think we have that right now.
Great, thank you.
All right. Additional questions? Any questions online? No. I guess, Seth, could you speak a little bit about how and what imaging markers are kind of maybe being included in clinical trials as far as to track drug response or slowing trajectories down?
Yeah, that's also a really great question. We've had pharmaceutical companies come to us and say, "Hey, can you do a bunch of imaging things and see which one might be sensitive to change over 6 months? Um, do we have anything that's sensitive to treatment in 6 months or even 3 months?" And I think we're all really working towards that. But I don't think that some of the quantitative imaging that we talked about here has been established well enough to be confident that this is a marker. But I think, you know, putting on my biochemist hat here for a minute, I think it also is important to understand what the mechanism of action is of the drug that's being provided and what it's looking to halt. Because especially in something like MS, there's not really a drug that is going to be given that somehow heals the central nervous system completely, and we can go back to a neurological function or neurological presentation prior to the development of MS. So understanding sort of what the biochemical target and the mechanism of action of the particular drug is maybe that opens up the idea of which methods we should study for sensitivity to that particular activity. And what's neat about that is you say, okay, that's great, let's do that. But as soon as you step your toe to that and say, okay, I want something that can look for a marker of microglia or macrophages, or maybe we want to look for some other aspect, and you find out that the vast majority of those methods have not been validated in the cord well enough to be confident that they are going to be sensitive to the exact action in just a few months. So we're sort of at that entry level here where we've got a lot of tools that are starting to be built, but there's so much work that needs to be done to establish what our confidence in the utility of those are for long-term clinical trials. And also understanding that not all these techniques can be easily adopted by clinics and non-academic enterprises. So there's a lot of work to be done to establish that, but I think there's also a lot of opportunity. I know that's a non-answer.
Yeah. No, great answer. Thank you.
Hi, thanks for the very interesting talk. I was wondering, you mixed a bit the results from like 3T and 7T, but maybe you can expand a bit on what are the benefits maybe of 7T for MS?
That's a great point. So there are advantages and disadvantages, certainly. Typically speaking, going to higher field increases our currency that we can spend for either higher resolution or faster scan time. But we also know that there are certain contrasts that improve at higher field. For example, the bold effect increases, or I'm sorry, I should say the bold contrast increases a little bit at 7T. We know that susceptibility imaging is preferred at higher field because of its ability to detect these paramagnetic contrasts. And there are other things like the spectral separation, the spectral resolution for CEST imaging increases at 7T. So there are a lot of benefits to go into 7T, but there's also a lot of challenges to go into 7T as well. For example, your T1 contrast change, your relaxation times change, your T2 star gets shorter. And I think when you're looking at things like the spinal cord, and I do have a point here at the end, but when you're looking at the spinal cord, where you have both a spatial and a temporal fluctuation in your magnetic field due to breathing, but also your bone disc interfaces, the ability to utilize all of that increased signal to noise to your advantage is a little bit minimized or mitigated, I guess, because we have to do so much to control for those types of variations and variabilities. But I've always been really quite astounded by some of the work that Virginia Ko has done and her work on quantitative imaging at 7T and diffusion imaging. And I really encourage you to have a look at some of those to see what can be done at 7T. But I think for us, the target for 7T is susceptibility. We want to establish and take advantage of the higher field for looking at those paramagnetic contrasts that may be of interest. The other thing that you have to consider, I guess, is that at 7T, fewer patients are able to be scanned at 7T due to hardware or surgeries or tattoos or things like that as well. So, 3T still remains sort of our gold standard clinical go-to, and that's why a lot of effort has been done to achieve some of these quantitative images at 3T. But things like susceptibility and fMRI, I think, have an advantage at 7T. But we're still early in the game there. There have been publications put out about, there are not really standard coils that could be used for spinal cord imaging. There are excellent coils out there, but they're not coils that 40 sites have. There's sort of a lack of thoracic coils for 7T, except for maybe a few one-offs. So there are still some challenges there at 7T for the cord, but I think the opportunity is pretty rich too.
Thank you. One last question, I guess. What tools have you been using for segmentation of lesions, and have you been quantifying like lesion load in the spinal cord? It may have been presented somewhat already, and I believe there's recently was a new tool released. Has anybody seen that? Yeah, correct. Just recently, right? Curious what you've been using, Seth, as far as spinal cord toolbox tools, and have you been using the automated MS lesion segmentator?
So I know that we use the spinal cord toolbox, but I would need to defer to our individuals who are in the trenches using the actual methods provided in the spinal cord toolbox for the segmentation. I know we do go back and validate those with radiologists, but I'd have to defer to our grad students and postdocs on what actual tool they're using within the toolbox. It's a great question. But I do know that all of us use as many features as the spinal cord toolbox team release. We use them. Really
Great.
helpful for that, actually.